Good morning. I will be talking on what causes metabolic syndrome. From the introductory remarks, all of you have gained an understanding on metabolic syndrome. I am a gastroenterologist. I do endoscopies and I am not a surgeon. So I will be presenting a medical physician's perspective of metabolic syndrome. Now this is what I do for a living. I see people with acidity. People belch, they burp, they have heartburn, they have tummy pains, and they come to me with what they call acidity. Now when I take a history and when I take their blood pressure, I see that they are hypertensive. I discover diabetes, and some of them may have had a stroke or two, or even heart disease. So the acidity that they came to see me with is only the tip of the iceberg. What is beneath the surface is metabolic syndrome. Metabolic syndrome is a combination of diabetes, obesity, high cholesterol, and hypertension. Over the last 20 years, the world has seen tremendous scientific progress. We all have vehicles to travel. We have cell phones. We can browse the internet while on the move. We have high-speed trains, air-conditioned buses, elevators, everything. We have every conceivable creature comfort. Along with this scientific progress came this imbalance. If you see, there is a balance on the screen. On the left, you see calories in, and on the right, there is calories out. When this balance tilts in one direction, there is a problem. When you do not burn out enough calories and you put in too much calories inside, the balance tilts in a direction. And this is the fundamental reason for metabolic syndrome. And over the next few slides, I will explain up to the molecular level how the syndrome affects every organ in our body. If you see the pictures, this is how our previous generation worked. And a lot of us, including me, have used a bicycle. I used a bicycle for 9 years in medical college. 5 years for MBBS and 3 years for MD and 1 year for pre-degree. Now we all use cars and motorcycles or mopeds or the bus or the auto rickshaw. Many of our parents walked several miles to school. I walked to my school. This is how our present generation works. This is what they do for a living. They sit inside a cramped cubicle. The only exercise they have is of the lumbricals. They move the mouse. This is what they do. And that is a scary existence. If you sit on a chair all day, stare at a computer screen, talk on your mouthpiece, it is not practical, it is not real, it is not conceivable. This is how we travel. We all have automated means of transport. Once we go back home, we watch television, we have a nice meal, and then we go to sleep. Our children come back home, they watch TV and they do some homework, do some games on the computer, have dinner and go to sleep. When I was growing up, we would play cricket until it was too dark to see the ball coming at us. And it was only then that we'd come back home. And the dinner at home is served in a sumptuous fashion. Rice is served on the table, and if we like the food, if the curry is tasty, we add more servings. And then we have conversation, we watch television, and we eat. So naturally, if you look at that window, more calories go in, and we are not doing any exercise. I am trying to say that we live the life of a lab rat in a cage. Look at this rat in the picture. All the rat has to do is to eat. So somebody pops open the lid and puts in food, the rat eats and just sits there. Do you not see a parallel between this rat and our own lives? I spent about 13 years outside of Kerala in the UK and US, and I came back after a gap. I've been back in Kerala for the last 3 years. What I discovered was the good part about Kerala. We are extremely literate, we are intelligent, all of us can read and write. Some statistics for you. Kerala has the most hospitals, most doctors, and the most hospital beds available for a given number of population. We can still boast of the lowest infant mortality, which means that babies don't die as quickly as the others do. The latest census has shown that life expectancy is highest in Kerala compared to the rest of the country. What is bad is Kerala is the most obese after Punjab. We are the diabetic capital not only of India but of the world. We are the heaviest consumers of alcohol in the entire world, and we consume the most meat in all of India. Kerala has other unique socio-economic problems. We are essentially a mail order economy. Our money comes from abroad. 1/5 of our economy runs on money coming in from our expatriates, NRIs. 1 out of 10 people in our state do not live here. That is a staggering number to live outside. Now, that leaves only 9% of Kerala's population in the state, and for those that live outside, half live abroad. They're not within reach. We have a rapidly aging population, and our state is full of empty nests where older people are living alone. These are unique problems that are special for our state. How do we take care of these people? As you get older, you're going to get sick. How do we take care of their health needs? More importantly, what will happen when the young population of today, that is, people in this audience, when we get old, what will be our health situation? Life expectancy. If you look at life expectancy, Kerala, from the 2003 data, 73, 70, and 76. Much higher. Say Maharashtra or Madhya Pradesh is 56. So our life expectancy is at least 10 years longer than other states. But remember, life expectancy comes from old people. These are the death rates of people that worked hard for a living. They plowed the fields, they cycled, they walked. These are not the life expectancy of this present generation. This life expectancy, if it was high, it is because our previous generation had put in tremendous physical exercise. You really want to think whether this generation who's sitting in front of a laptop all day will have the same life expectancy. And again, this is connected with metabolic syndrome. I'll go a little bit into the economics of healthcare. Food inflation is 11%, overall inflation is 10%, which means something that costs 100 rupees this year will cost 110 rupees next year, and so on. Healthcare premiums have gone up 20% in 2010. If you calculate retirement age at 60 and life expectancy is 80, you're leaving 20 years of no earnings with failing health. Now that is a serious problem. Now with that, I'm going to say a prophecy. With all of my experience, I think something terrible is going to happen. We are going to see a tsunami that is going to come at us in the next 15 years. That's a tsunami of lifestyle diseases, stroke, heart attack, cancer, early deaths, depression, obesity, and so on. An article published in the journal Nature in 2006 says very elegantly, collectively, these metabolic diseases constitute the greatest current threat to global human health and welfare. So this, my friends, is the greatest threat that we face. Metabolic syndrome will wipe out large numbers of our people. What can we do? So the remainder of the talk, after going into a bit of molecular detail, I will present my views about what we can do. There is a new term called MET inflammation. What is MET inflammation? It is a short form for metabolic inflammation. When metabolism goes wrong as a result of inflammation, you get MET inflammation. You see, there's smoking. All of these are lifestyle problems. There's smoking, starvation, excess alcohol, bad diet, overnutrition, inactivity, pollution, overexercise. All of this is put in the circle leading to obesity, and then there is oxidative stress and insulin resistance, which comprise what is called MET inflammation. Since today's theme is metabolic syndrome, I'll present a little bit of history. It was discovered, if you will, in 1923, when somebody found that more people with hypertension were also a diabetic. It did not take a great scientist to say that. Over the years, many names have been given. When we were in medical school, we heard about syndrome X, and then came the term metabolic syndrome, and the new IDF definition, which is the International Diabetes Federation. This is their definition. A big waist along with two of any of these: high triglycerides, low HDL, abnormal glucose, and high blood pressure. This is metabolic syndrome. Comes in various names, they all mean the same. It is a dangerous cluster of symptoms. These people are 3 times likely to have a heart attack or a stroke and are 5-fold risk of developing diabetes. And with our ethnicity and genetic makeup, we are at increased risk compared to the Western population. Indians have the highest risk of heart disease in the entire world, all other parameters being equal. We are genetically programmed to die earlier, so we have extra work to do. Why it happens is very clear, but how it happens is not fully elucidated. There is insulin resistance, which is a central theme. It is a pro-inflammatory state which is connected with various hormones. You see, this is a long slide with a bunch of molecular names. I will explain one by one. Insulin resistance means there is too much insulin in the body which cannot work. insulin is not able to work. And Dr. Praveen will be talking to us more about insulin resistance. Then there is elevated BMI, or the body weight has gone up. And then your blood glucose level goes up, blood pressure goes up, blood fat level goes up. And more importantly, we have all of these inflammatory markers, C-reactive protein, tumor necrosis factor, and the more recently talked about interleukin-6. These are the bad molecules. They are connected with metabolic syndrome or stemming from the extra fat that we store in our abdomen. This slide talks about how insulin acts on the body. If you see, this is a cell membrane. Glucose comes from outside into the cell. And for glucose to enter the cell, you need insulin. So how does insulin work? Insulin comes and sits on this insulin receptor. And once the insulin sits on the receptor, it's like a key turning a lock. When the key opens the lock, a chain of reactions happen inside. One, glycogen gets made. There is glycolysis producing pyruvic acid, and then there is fatty acid synthesis here. What is interesting is when insulin sits on the molecule, there is this glucose transporter 4, GT4 molecule, which is hiding somewhere inside the cell, gets transported magically onto the cell membrane, allowing glucose to come inside. So this shows that insulin allows glucose to enter the cell and then get used in various ways. And when this mechanism goes wrong, it is called insulin resistance. Now, as with any reaction involving a receptor, a problem can happen at the receptor, before the receptor, or after the receptor. So any of these can lead to a problem with the working of insulin on the body, or insulin resistance. Briefly, pre-receptor problems include a wrong type of insulin, anti-insulin antibodies, and then receptor problems, problem with the receptor. The binding can go wrong, there can be a mutation, the molecule can be wrongly made, there can be an antibody against the receptor. Post-receptor, in the slide, whatever happens following the lock and the key mechanism, any of those steps can go wrong. This is an interesting study worthy of mention here. Elegant study done on rats, published in 2004, Journal of Experimental Biological Medicine. What they did was they had two sets of rats. One set of rats was given a sucrose-rich food. Sucrose is cane sugar. So these rats were fed with a lot of cane sugar, and the other rats were given normal food. Guess what? The rats that got the sucrose-rich food became fat. After 20 weeks, they developed abdominal fat, liver fat, and plasma fat. Their triglyceride levels went up, their insulin levels went up, the plasma glucose went up. Eventually, it produced an imbalance in the fatty acid levels in the blood. The monounsaturated fatty acids, the MUFAs, increased, and the PUFAs, the polyunsaturated fatty acids, decreased as a result of this. This study showed not intake of fat that leads to accumulation of fat, but it's carbohydrate. We guys eat way too much carbohydrate. This study clearly showed that if you eat too much carbohydrate, you're going to get fat in the middle and have abnormal fats circulating in the blood, and insulin will not work. That is why the insulin level went up in these animals. This slide shows what is called visceral fat distribution. Seen on the left is the CT scan of the abdomen of a lean person. The white is fat. To the right is seen the same cut of a person with higher BMI. It shows that even though the proportion is the same, the amount of fat in the body proportion is the same, the amount of fat in the CT scan in the intra-abdominal cavity is higher. This scan was developed by Biju Matthew, who I work with downstairs, and I had him do a color enhancement on a CT scan on one of our own patients. This is the sliced section of the mid-abdomen of a person whose BMI was just 23, normal BMI. Incidentally, this patient had diabetes and heart disease. What is seen in blue is fat. So all of this is fat. The green is muscle and the red is bowel. So you can see from this scan that what we think as muscle is not muscle. What we have in our middle is almost 80% fat. And this fat is not just a benign lump of tissue. It is metabolically active. It sits and makes all these poisonous molecules. Platelet aggregation inhibitor, interleukin-6, tumor necrosis factor, and then there is something called adiponectin, which is a protective hormone, and people that are fat produce less of this. So the center theme is an imbalance of the molecules leading to an altered cardiometabolic risk profile. You see coronary atherosclerosis setting in, the blood vessels start getting blocked. Fat gets deposited in the liver, insulin levels increase, LFTs become abnormal, and the muscles become resistant to insulin action. All of that happens because there is too much fat in the abdomen. Central obesity and insulin resistance, they propel each other. They go hand in hand. What are the investigations we can do? We can do a DEXA scan, we can do MRI or CT to estimate the fat. We can check the cholesterol and the lipid profile. We can check fasting insulin levels and the C-peptide levels to see how much insulin is being made. We can check inflammatory markers that I've highlighted, the C-reactive protein, tumor necrosis factor, and interleukin-6 in labs. We can measure the inflammation. Among these, the high sensitivity C-reactive protein is available for common use. Insulin resistance naturally is associated with a bunch of problems: cholesterol, blood pressure, uric acid, glucose intolerance, high triglycerides, and metabolic syndrome. This is how you identify insulin resistance, by measuring the plasma glucose. The plasma insulin can be measured, C-peptide, measuring the blood pressure. All of these together will lead to the diagnosis of metabolic syndrome. Clinically, when you examine a patient, if you see this, it is called acanthosis nigricans, a dark pigmentation in the neck area. It can be seen in the front or the back or under the armpit. This is the axilla of the patient showing a dark pigmentation. This is one of the clinical signs of metabolic syndrome. You must do a complete risk profile of these patients. Ask them if they smoke, how much they exercise, what food they eat, how much and when. Check their blood pressure and blood sugars. Screen them for heart disease if appropriate, and do a detailed assessment on these people. Now, as you will all know, other causes of acanthosis include cancer. So these are patients that will anyway require a detailed examination. So beware of acanthosis nigricans. Another picture of acanthosis nigricans, you can see this hyperpigmentation on even the extremities. So back to our question, I'm going to present my view about what we can do. So I've painted a dire picture, I'm going to give you the detail, how it happens. So this is what I think we can do. As doctors and as healthcare workers, we must recognize the tsunami before it hits us. Once people start dying in large numbers, it's too late to intervene. We must intervene now. We must make preventive health our number one priority. It is not just enough to write medicines or give injections. We must act on preventing this condition. We must encourage healthy lifestyle, awareness, and healthy networking. And I will focus a little bit on this, healthy networking. Healthy networking is a new concept in medicine. When we were in school, we were told that if you associate with bad people, bad things will happen to you. And if you associate with good people, good things will happen to you. It is well known in the financial world that if you associate with people that are wealthy, your wealth status will improve. Now that theory is true in health as well. We must encourage people to form healthy networks. People that talk continuously and with interest about their own health, their other people's health, and talk with each other. They must have a health network. A classic example, a small example, is Sunrise Hospital. If you look at the doctors at Sunrise Hospital, none of them are obese. And over the last 3 years, the average body weight of the doctors and many of our staff have come down. Did you know why? Because we constantly talk about it. We hold CMEs, like the minister pointed out. We hold CMEs on this. We create an awareness. Many of us go to the gym, including me. I went for a half an hour today morning, I'm proud to say. All of us do it sometime or the other. We lead healthy lifestyles reasonably within our limits. That's what I mean by healthy networking. We must encourage our patients to do that as well. We must educate our patients to take care of their health better, starting as early as they can. And now for the big picture, this is called the 30,000 foot view. What is the best strategy? Once somebody becomes a diabetic, yes, they can have medicines, injections, surgeries, cures, all of that. But what do we do before that? What is the best strategy against metabolic syndrome? This is where we must start. We must start at this population that is growing in our country. We must educate them about a healthy lifestyle and explain the reasons why they should have a healthy lifestyle. If we just tell them to eat healthy, they'll say, go to hell. But if we explain to them the consequences or the benefits of certain health habits, these kids will listen. And I'm proud to say that I actively practice what I just said. During my lunch hour, I visited over 36 schools in the district. I talked to them about health, lifestyle, smoking, alcohol, diet, exercise. And I hold Q&A sessions with the children and the teachers, explaining to them why certain health habits can cause problems. So this is what I believe we can do, and I thank you for your attention.